I would like to welcome everyone watching this virtual presentation, wherever you are. On behalf of my co-investigators, it is my pleasure to share with you the primary endpoint results of the Untouched study. My disclosures are listed on this slide. The subcutaneous implantable cardioverter defibrillator, or SICD as it is better known, was designed to provide protection from sudden cardiac death while reducing complications compared with transvenous leads. However, relatively high inappropriate shock rates, particularly for T-wave oversensing, have been reported with early SICD devices and implant techniques. The most common indication for ICD therapy is primary prevention with a reduced ejection fraction. Such patients have been underrepresented in prior SICD studies, which tend to enroll less sick patients. To date, no prospective study has evaluated outcomes with the SICD using contemporary devices and programming in a primary prevention population with left ventricular dysfunction. The hypothesis of the Untouched study is presented here. The Untouched study hypothesis is that the incidence of inappropriate shocks at 18 months in primary prevention low EF patients will be non-inferior to the rate in transvenous ICD patients observed in MADE-IT, high-rate and long-duration arms. Untouched is a global, multi-center, prospective, non-randomized trial. De novo implant patients were enrolled at 110 sites and were followed for 18 months. Devices were prescriptively programmed with a conditional zone set to 200 beats per minute and a shock zone of 250 beats per minute. Patients were enrolled if they had a primary indication for sudden cardiac death, an left ventricular ejection fraction of 35% or lower, no pacing indication, and if they passed the SICD screening vector test. The study's primary endpoint was an inappropriate shock-free rate at 18 months compared to a performance goal of 91.6%, which was derived from the inappropriate shock rate of 94.6% measured in ICD patients in MADE-IT study arms B and C. Untouched secondary endpoints were the all-cause shock-free rate at 18 months with a performance goal of 85.8% and a system and procedure-related complication at 30 days. Of note, this latter endpoint was previously reported and published. Implants were attempted in 1,116 patients. We report endpoint analyses on the 1,111 patients who received devices. The characteristics of the patients are shown on this slide. Of note, the mean age was 56 years with an EF of 26% and 88% had heart failure. Most patients had ischemic etiology. Compared to other SICD studies, the untouched patient population is sicker with lower ejection fractions, more heart failure diagnoses, and a higher rate of ischemic etiology. However, the patient cohort is similar to that in landmark transvenous ICD studies such as MADE-IT, SCUT-HEFT, and MADE-RIT, except that they were a younger population, presumably due to the pacing indication exclusion criterion. The primary endpoint results are shown on this slide. The inappropriate shock-free rate is 95.9% at 18 months, with a 95% lower confidence limit of 94.8%. These results significantly exceed the performance goal of 91.6%. It is noteworthy that the inappropriate shock rate noted here is very similar to the 94.6% observed in MADE-IT arms B and C. Multivariable predictor analysis shows that patients with a history of atrial fibrillation, non-ischemic etiology, and lower ejection fraction were more likely to experience inappropriate shocks. Procedural characteristics that predicted fewer shocks for the patients were implantation using the 3-incision technique and implanting devices with the SmartPass filter. This feature is the latest technology improvement intended to reduce the risk of inappropriate shocks. Subgroup analysis showed that the inappropriate shock rate over 18 months is only 2.9% in patients implanted with SmartPass technology with extracardiac oversensing markedly reduced. A comparison of inappropriate shock rates from SICD and transvenous trials is shown in this slide. The one-year inappropriate shock rates measured across the SICD studies have decreased substantially over time. The annual untouched inappropriate shock rate were found to be lower than those recorded in recent transvenous ICD studies using modern devices and programming strategies. Indeed, the one-year inappropriate shock rate for untouched is the lowest recorded to date for large multi-center trials. The secondary endpoint, the all-cause shock-free rate, is shown on this slide. The shock-free rate was 90.6%, significantly meeting its performance goal of 85.8%. Significant multivariable predictors of all-cause shocks are a history of atrial fibrillation and lower ejection fraction, as shown on the bottom panel of this slide. The untouched patient cohort experienced a total of 64 appropriate shocks in discrete episodes. The first and final success shock rates were 92.2% and 98.4% respectively. The one episode with a failed final shock converted spontaneously. Of note, this is very similar rates of success compared with transvenous studies. 7 subjects collectively experienced 58 episodes in 9 VT storm events. All of these storm events were successfully converted. The overall survival rate of this cohort was 94.9% at 18 months. Of the 53 deaths reported during the 18-month follow-up, 26 of which were classified to be of cardiac origin, including 3 arrhythmic deaths. These 3 deaths were due to pulseless electrical activity or asystole. In conclusion, the Untouched study shows high SICD efficacy and safety with contemporary devices and programming despite the sickest cohort studied to date. The inappropriate shock rate, which was 3.1% at 1 year, is the lowest reported for the SICD and lower than many transvenous device studies using contemporary programming to reduce inappropriate shocks. I want to again thank all of the Untouched investigators and sites who did the hard work on this study to make this presentation possible. Thank you.
This is Dave Callens with Dove commentary on Dr. Gould's. The subcutaneous ICD has evolved considerably since its IDE approval. There's been significant improvement in sensing to exclude inappropriate shocks, which was a yearly incidence of 13.1% in the IDE. And its extension to use in primary prevention in structural heart disease instead of electrical heart disease. This is the background for the Untouched study, which had an important hypothesis that the SICD would be non-inferior to contemporary transvenous ICDs using mated RIT as the comparator in freedom from inappropriate. Dr. Gould presented registry data from over 1,100 patients with an ejection fraction of less than or equal to 35% and primary prevention indications for ICD. The population was similar in sickness to transvenous ICD trials, and there was an 18-month follow-up. The freedom from inappropriate shocks in 18-month follow-up was 95.9%, which surpassed the non-inferiority margin of 91.6%. The study was able to determine predictors of inappropriate shocks, which included history of atrial fibrillation, non-ischemic cardiomyopathy, and lower ejection fraction. There are also some important predictors of freedom from inappropriate shocks: the use of a 3-incision implant technique and the implant of a Generation 3 device which had improved sensing algorithms. I think the Untouched registry was a very important trial. It successfully demonstrated in a large population of patients a remarkable reduction in inappropriate shock incidence with improvement in technology and programming. Thank you.
This is Usha Tedrow from Brigham and Women's Hospital in Boston, and I'm providing the commentary on the Untouched trial primary results. First, a little context. Untouched is an important study because it addresses concerns regarding inappropriate shocks with the subcutaneous ICD. Inappropriate shocks were 13.1% in early SICD studies. The SmartPass filter is essentially a specialized high-pass filter that can reduce the amplitude of lower frequency signals from the surface ECG, for example, from T waves. It reduced the annual rate of inappropriate shock to 4.3% in data published from 2018. It is not clear what proportion of the patients in Untouched had a device enabled with the specialized filtering, but it was a significant independent predictor of lower IAS burden in the study. A small commentary about the study design. This is a single-arm observational cohort, not a randomized trial as is customary for a non-inferiority trial. The comparison group is the mated RIT treatment arm B and C, which were used as a historical control for a derived performance goal. So it's important for us to think about how the mated RIT population might differ from the population in Untouched. The SICD patients in Untouched had no pacing indication and had to pass the ECG vector screening. Additionally, in mated RIT arms B and C, about half of the patients received a CRTD, perhaps indicating a sicker cohort. Here are some other differences between mated RIT and Untouched. As mentioned by Dr. Gold in his presentation, the mated RIT patients were about 10 years older. Additionally, there was a higher proportion of NYHA class 2 and 3 heart failure among the mated RIT patients. However, there were more patients with atrial fibrillation in the Untouched population, which was a risk factor for developing inappropriate shocks itself and should have biased towards the null. To summarize, Untouched showed that in a non-randomized cohort of patients that the SICD has a low inappropriate shock rate of 3.1%. A randomized trial would be ideal for comparing transvenous and SICD inappropriate shock rates to establish non-inferiority. Untouched additionally provides some important corroborating evidence that adding specialized high-pass filtering can further improve the inappropriate shock rate for the SICD. Thank you very much.